I would request Dr. Dipendra Sarkar to go ahead with the next topic, that is TNM staging and LABC. Over to you, sir.
Can you add me as a co-host?
Yes, sir, sure. Yes, sir.
Okay, thank you. Now, the next presentation is actually not my own presentation. This is a presentation which is being created by the Association of Surgeons of India, a skeleton format which we follow wherever we take the module, and PIDAT 3 was out of the module. So this is a template that we use, and if anybody wants to use the template, he has to declare right at the beginning that the disclosure is all the content presented is the property of ABSI, copying of content permitted without the secretary permission. So I put this as a disclaimer and the disclosure right at the beginning. Well, this is a topic which comprises of two lectures. One is the TNM staging and the other one is LABC. Now, TNM, most of you know, and many of you would be able to go into your phone right now and understand what it is. So coming fast to the T1 tumors, as you all know, you can subdivide into T1A, T1B, and T1C, depending on less than 0.1 to 0.5 to 0.5 to 1 centimeter, between 1 to 2 centimeter, and of course, without any involvement of the skin. And T microscopic disease is up to 0.1 centimeter. T2, of course, is 2 centimeter, less than 5 centimeter, and T2 is 5 centimeter or more. There is no confusions. T4A is when there is a chest wall involvement. T4B, again for postgraduates, the important point to understand that serratus anterior is part of the chest wall. Pectoralis major is not part of the chest wall because it's a sacrificable structure. So T4A means chest wall does not mean the pectoral group of muscles. Whereas T4B means involvement of the skin, and then there are the criteria is ulceration, there is satellite nodules, or there are poderonge. If you find these three things, these categorize as a T4B lesions. T4C is add-on between T4A and T4B, and T4D is an inflammatory carcinoma. Now again, the trainees need to understand that there can be poderonge present in many patients. But when you have a patient who presents with the inflammatory signs, that is redness, you do not find a well-defined lump, number 2, and number 3, you find that there are poderonge which involves at least more than half of the breast, then it comes out as an inflammatory carcinoma. But if you have a localized area of poderonge above a lump that does not categorize as a T4D lesion, it would categorize as a T4B lesions. So you need to understand the most important consensus statement as signs of inflammation, ill-defined lump, more than at least half of the breast or 1/3 of the breast to be involved to categorize it as a inflammatory carcinoma. In the node, as you know, N1 means there's a palpable node in the ipsilateral axilla. N2 again is A is when you have a node which is fixed. It involves the ipsilateral axilla. N2B is when there is an ipsilateral internal mammary node. And believe me, when they talk about that, they are adding a sort of clinico-radiological, because it is very difficult to actually understand. Though we were taught that a percussion is a technique, but practically it is impossible. So a mild extension into an ultrasound to find out whether there is an ipsilateral internal mammary node is present or not. And these are the diagrammatic representations. N3 is infraclavicular or internal memory, or you have supraclavicular. Now, the important thing that you need to understand, again, trainees, is at least 5 years back, we were taught that presence of a supraclavicular node means it's an M1 disease. But the important change that happened in the last couple of years is that the presence of supraclavicular node is a regional disease. It does not categorize as a metastatic disease. However, from the treatment point of view, nothing changes. You are going to start with a systemic therapy, not with a surgery, and you are not going to go for a neck dissection in them. But from the biological pattern of the disease, a supraclavicular node has been categorized as an N3 disease. And this is the pictorial representation. You are going to find it as such. Now, when you go for pathologically, again, the P stage is quite simple. But when you go into the nodal status, when you have, they have added that if there are microscopic disease, then you have to tell it's a microscopically positive axilla. Even isolated cancer cell presence is categorized as a significant disease. And based on that, there is an implication in terms of sentinel lymph node biopsy. But again, as I must re-emphasize the fact that our pathologists would not spend time to find an isolated cancer cell or categorize a lesion to be micrometastasis less than 20% or less than 2 millimeter involvement. But theoretically, you must understand these are examples of microscopic disease. Then you can categorize it as 1 to 3 nodes, 3 to 9 nodes, or more than 9 nodes. And therefore, you can categorize as a PN1, PN2, or PN3 disease. And these are examples how you classify them. Now, coming to metastasis, again, you note the change. M0 is no metastasis and M1 is metastasis. Now, once there are companies who have come out with circulating cancer cells or circulating DNAs, they have added this terminology called CM0I+. That means they have got isolated circulating cancer cells. Now, what would be the impact of this in clinical practice is at present debatable, but that's a new addition or an add-on that has been given in the TNM. The recent TNM has also, apart from the stage grouping, which again most of you know, the recent TNM has also included precision medicine, which I am not putting because the module does not permit to put in and make things so complex as precision medicine to be part of the stage grouping. Now, therefore, we are faced with diseases which are early breast cancer, which are potentially curable, to locally advanced, which are absolutely curable, to locally advanced breast cancer, which are potentially curable, to once they become metastatic, it is incurable, though of course with the recent advances in the molecular biology and the molecular targeting, we are able to extend the survival for 5 years or even more than that. So coming to the second part of the talk, which is the locally advanced breast cancer. Now, by definition, a locally advanced breast cancer is one in which you have a lesion which is quite big, and how big? It's more than 5 centimeters. Number two, there is involvement of the overlying skin, or there is involvement of the chest wall, and or involvement of the axillary lymph nodes in terms of fixity to each other or to the axillary vessels. Add to that a single point. There is no evidence of systemic spread radiologically at the time you saw the patient, or by PET-CT at the time you saw the patient. So therefore, residents must understand that when we talk of these, we are actually talking of these T status. We are talking of lesions which are like these, or lesions which are like T4A or T4B or T4Z and T4D, which already we have discussed at the beginning. Now, this is a classical example of Pate, and again note the involvement of all the quadrants of the breast to tell that this is an inflammatory carcinoma. There are signs of inflammation and there is no well-defined lump in these lesions to categorize as an inflammatory carcinoma. This is again an example of how a locally advanced breast cancer, and I'm sure most of you have seen pictures which are more horrible than what you see. And a favorite quote by one of our senior professors is that the West didn't know this, so they have only restricted it to T4 disease, or else they would have classifications going up to T10 lesions. And these are classical examples of quote unquote with a smiley, something called a T10 lesion. Now, this also we have discussed, so I'm not going into the details of this. Now coming to this, now look at this. We have got two different categories of locally advanced cancer. One is a large operable breast cancer. The other is a locally advanced breast cancer. Now, locally advanced actually means surgical approach is not possible at the time when the patient presented to you. Now, let us look at the data. What happens if you give chemotherapy first and then go for surgery? On the contrary, if it's a large operable cancer, you do surgery and then go for chemotherapy. The overall survival is the same, be it surgery fast followed by chemo if it's operable, or a chemo fast followed by surgery. The outcome is same based on the biggest meta-analysis done by a gentleman called Mori et al. But what varies is the incidence of breast conservation surgery. In a large operable breast cancer, if you give chemotherapy, you can downsize it to a state where it becomes BCTable. So the advantage of neoadjuvant chemotherapy, apart from the fact that it sterilizes the micro metastasis that you can have, is to convert a mastectable lesion to a BCTable lesion. Now, what is the amount of workup? Now, number one, it begins with triple assessment. And though they have put it in this template as FNAC, but as I said, there is whatsoever no debate that you must do core biopsy only. The question is why you should do a core biopsy. It's not just only the diagnostic accuracy, the specificity, sensitivity goes up. It's not only because of the fact that you can get the ER, PR, HER2, Ki-67 right at the beginning, and therefore you can plan your neoadjuvant systemic therapy accordingly. But again, postgraduates, try to understand what you do in the operating room. You take out a breast, and the breast, after a mastectomy, the breast is there. You complete the whole thing, and then a resident comes and drops it into a formalin. And then the specimen is there in the theater for 2 days, and then the specimen goes to the lab after the weekend is over. So what happens in the whole process is there is some amount of denaturation of the tissue. So even a ER positive, PR positive, HER2 positive cancer might become a triple negative breast cancer. The advantage of doing a core biopsy right at the beginning is you take out a tissue and you send it immediately into formalin, and it goes into the lab within 5 to 10 minutes. And therefore, the chances of the lesion showing positivity is higher. So do a core biopsy. Apart from it increases the diagnostic accuracy histopathologically, it also increases, or rather reduces, the chances of false negativity in immunohistochemistry, and therefore core biopsy is the standard of care. The question is metastatic workup to what extent? Again, there's a big debate, and I would not dwell myself into the debate, but what I am going to tell for residents or trainees, the answer is I'm going to go for a CT thorax, I'm going to go for a CT abdomen and a pelvis and a bone scan. Stick to that. That's an exam answer. You can put it into one bag, do a PET CT scan, and there are reports which evolving, and NCCN would tell that's an institute's choice. But the NHS guideline and most of the international guidelines do not endorse PET CT. The question is why, in spite of everything, PET-CT has not been endorsed. The reason is very simple. The reason is PET-CT has got a wonderful specificity and sensitivity in terms of bone mets, but poor sensitivity and specificity in terms of liver and brain mets. So therefore, the standard of care continues to be a standard CT thorax and abdomen and pelvis and a bone scan for a diagnostic workup. So this is what we have discussed. So again, I must re-emphasize that when you do a core biopsy, you must understand that this core biopsy increases the false negativity rate of an immunohistochemistry. And this is what is the standard guideline that I have already suggested. You can choose to have an ultrasound and a chest X-ray, but that's not part of the guideline. You must endorse CT abdomen and pelvis and CT thorax and bone scan as the standard of care and utter that during the exam. So this is the workup in brief. You are going to go for a triple assessment, and once you understand that it's a metastatic, it's a locally advanced breast cancer, you are going to do a metastatic workup. Whereas if you see it's an early breast cancer, you should routinely not be doing a metastatic workup. However, if there is a signal in the postoperative histopathology or the pattern of disease like a triple negative breast cancer with aggressive variants, you are allowed to go beyond the purview and do a metastatic workup. But by and large, early breast cancers do not need a metastatic workup, whereas locally advanced breast cancer mandatorily has to go that. The next important thing is whether to place in a clip. As a rule, if you are planning to do a mastectomy, it doesn't matter whether you do a mastectomy even after a complete pathological remission. So that is a gastrectomy. It's very simple. But if you're planning to do a breast conservation, mark my point, it's an absolute necessity to put in a clip after you have a confirmed diagnosis or at the time when you are doing a core biopsy inside the core of the tumor. Again, there is a controversy. How many clips? Are you going to put the clips in the periphery? The consensus is 1 or 2 clips at the core, because you expect the whole thing to shrink down like this. And it is the center that becomes the post neoadjuvant chemotherapy shrinkage volume is the volume which is your target for resection as well as radiation boost. So there is no point in putting in clips in the periphery, number of them, to understand what is happening. So the rationale of treatment again is neoadjuvant therapy. And there are arguments which I can argue against that, but as a standard thing, it takes care, it sterilizes the system. It downsizes the lesion. It is partly a sensitivity test to understand whether the chemotherapy is going to be sensitive in this individual or not. The question comes is how you are going to evaluate the response. Response evaluation is done by clinical and ultrasound. You can choose to have an MRI or a PET-CT, and the PET resist or the MR resist criteria, but that is not a tool to be used in between the cycles. You can start with an MRI, you can end with an MRI, and in between it's clinical and ultrasound. You can start with a PET-CT and end with a PET-CT, in between it's clinical and ultrasound. You can start with a mammogram and end with a mammogram, in between it's clinical and ultrasound. If you start with a clinical and ultrasound, continue with a clinical and ultrasound, and the last report should give you the idea when to operate. The next important thing is the neoadjuvant therapy. It's a multimodality therapy for sure, and you can use many of them. The question is how many cycles? Let us come to this. Now, these are the facts that has come out. Number one, it reduces, as I said, NACT reduces the need for mastectomy. That's a level 1 evidence. Clinical response is an important predictor of response. That's a level 1 evidence. Complete pathological response and the node of the primary node predicts outcome. That used to be something. The recent consensus, this is not an updated version of the presentation. The recent consensus is Yes, it holds true for aggressive triple negative breast cancer, not so much in terms of the luminal cancers. Do not offer survival benefit. Again, as I said, whether you give fast surgery and then chemo, or chemo fast or surgery, doesn't impact. Same is the case for local recurrence. But what it does, as I said, it increases the breast conservation rate. It sterilizes the system. It is an in vivo test for chemosensitivity, and improves local control and disease-free survival to certain extent. Now, this is the classical one. You can have a complete response, you can have a partial response, or you can have a progressive disease depending on the percentage that has responded. Now, what chemotherapy regime? Again, this is again an old slide, but what I would tell postgraduates need to understand that in today's era, when we choose a particular form of systemic therapy, we are guided by the age and the biological character. Now, if this lady is 45 years of age with a triple negative cancer, I would start with a taxane. If the same patient is 83 years of age with a triple positive cancer, I would start with anastrozole. If the patient is 43 years of age with luminal A cancer, HER2 and negative, then I would start with neoadjuvant therapy with CAF or AC or AC. I am not going to start with taxane or then. So this is a classical example of choosing a regimen depending on two things: the age of the patient and the biological character of the cancer. The optimal duration of chemotherapy. Now, there are various words written in this template, but what you need to understand, the consensus is very clear now. Whether you have to give 6 cycles and then operate, you give 3 cycles or operate. So we have had this debate so many times. Most of my colleagues, Dr. Neeta Nayar and Vani Parmar, they have argued with me that you must use 6 cycles. Why I always felt that if you can go for after 4 cycles, you can go for breast conservation, you can go for breast conservation. And the recent consensus that have come of late is for a triple negative breast cancer, mark my word, for a triple negative breast cancer, you exhaust all the cycles preoperatively, then you operate. For a luminal cancer, which is not going to be so much chemosensitive, you find that it is now an operable cancer, you go ahead with surgery. After 3 to 4 cycles, there is no harm. So the answer to the question, my trainees, is that you are going to use 6 cycles mandatorily if it's a triple negative cancer. In other cases, you may use 6 of them, but you can use 4 cycles and then go ahead with surgery. And again, now what are the steps that you take for adequate mastectomy? Now, avoid skin puckering, avoid subcutaneous bulge. Now, if you take too much of skin, then it becomes it's completely a skin closure under tension. If you keep too much of a skin, then it becomes a bulge and it looks like an inadequate mastectomy. You must have, and most residents would begin and focus on a flap which is extremely thin, and they end up in a flap necrosis. So the flap has to be optimum. Again, in the next phase, after you have had 2 or 3 flap necrosis, you try to be more conservative and leave behind some of the tissues, which leads to late chest wall recurrence. Now, all these patients must mandatorily, whether you are doing a breast conservation or you're doing a mastectomy, must have a drain placed. And therefore, the practice that you put in a drain, do not put in a drain and try to build up a contour of the breast is now into oblivion. All patients mandatorily must have a drain in place. Whether you give a low suction or a no suction drain, the choice is yours, but you must put in a drain in all of them. And after you have taken the whole thing out, you must mark it with single suture, a short superior or a single clip and superiorly, or a long lateral suture and try to put it at level 1, level 2, level 3 separately if you are doing all 3 levels of dissection in that particular patient. The question is, are you going to do a breast reconstruction? Most of the evidences currently suggest that early breast reconstruction or primary reconstruction is the standard of care. The only problem is you should not be using an implant if you're contemplating a radiation, because most of your patients of locally advanced breast cancer will require an implant. And if you choose an implant, radiation doesn't go. So it has to be an autologous implant, autologous reconstruction in those cases. But as I said, the standard of care is an early or a primary reconstruction, except of course you are unsure about the margin. And in those cases, you complete the procedure, complete the treatment, and go for reconstruction after 2 years. Now, all patients who have had a locally advanced breast cancer, irrespective of what you do, must have a radiation. For a breast conservation, it's a cavity boost and a whole breast irradiation, whereas for a mastectomy, you are going to have a chest wall irradiation. And if there are more than 4 nodes, you are going to irradiate the axilla. If there is extracapsular disease, you are going to irradiate the axilla. Hormone therapy, again, yes, as I said, if it's a ER or a PR positive cancer, depending on the age, you choose to have a tamoxifen or you choose to have an anastrozole or a letrozole. Now the consensus is shifting towards 10 years of use. And therefore, one need to tell them that you have to use this for 10 years. There are certain trials where after giving tamoxifen in a premenopausal lady, you find that they have attained biological and biochemical menopause. In them, you can shift to an aromatase inhibitor. The follow-up schedule, again, the standard setup, not looking into the slides, is that I would follow up a patient at 3 monthly interval for first 2 years and 6 monthly interval for next 3 years, and then a yearly checkup. You can choose to have the radiological evaluation done once a year. The role of CA15-3 as a marker in follow-up is non-evidence-based and now has gone into oblivion. So this is a very complex slide where I'm not going. So the summary, as I said, that combined modality of treatment becomes the standard of care, and neoadjuvant therapy, endocrine therapy, as I said, can be given in patients who are elderly patients and who are ER positive patients. So thank you very much. Happy to take any questions.
Thank you, sir. I would request Shinde sir to add on his comments.
Sir, hello.
Yes.
Sir, your presentation is absolutely crystal clear, but I have some questions for you for PG, so that they could understand why such a staging is there. So my first question is, what is the current status of non-invasive lobular tumors?
Sir, I didn't get it. What is the current status of?
Non-invasive lobular tumors, whether they are considered as a carcinoma or they are classified as a benign.
Okay. So the answer to the question is, lobular in situ cancers are not considered as a cancer, but it is a high risk marker, and there is a possibility that these patients might develop a cancer later on. So these are markers, but they are not precancerous lesions, whereas DCIS or in situ cancers can progress from in situ to an invasive cancer, and LCIS can develop an invasive ductal cancer. So an LCIS will not necessarily go into a lobular cancer. So the role is, it's a marker only. The second point is LCIS is seldom, if ever, they are picked up in radiology. So it is usually a chance finding after an excision that you pick up an LCIS, and then you tell the patient that there is a possibility you are at a higher risk. And there are studies to suggest that LCIS may be a surrogate marker for BRCA positivity. So they have to be put on an intensified screening.
Yeah, correct, sir. Thank you. Second is, why such a upgrading of the size from 0.5 centimeter to 1 centimeter to 1 to 2 centimeter and 2 to 4 centimeter? What is the basic behind that? That we just should understand why such upgradation of the size of the tumor, and
Okay.
what is the rounding up of the tumor size?
Okay. So the first is now PGs need to understand that the perspective of the West and the perspective of this country is different. In India, we would never find a 7 millimeter lesion. It's usually a chance finding. But in the West, getting a 7 millimeter lesion is not a big issue because they have a dedicated screening program. And they also feel that a screen detected cancer is biologically less aggressive cancer compared to a symptomatic cancer. So because the West sees so many of these cancers, they have subclassified the T1 into various categories. Number two, 2 centimeter is a cutoff above which most of the studies, the last one that came up in 2000, which is called the spectrum model, which quotes that most bluntly, I mean, if you don't look at the lymph node, if it 2 centimeter, then it is found that there is a chance of systemic spillage roughly. Though, of course, 1.2 centimeter can metastasize, a 4 centimeter may not metastasize, but the probability of the lesion metastasizing increases once it crosses the 2 centimeter mark. So too has been kept. 5 centimeter is because of the fact that way back in 1980s, there was a trial which came up from San Antonio, which told that lesions which were more than 6 centimeter behave very abnormally, and their aggressiveness increases once it goes more than 6 centimeter. So they had sort of made a compromise to put it at 5 centimeter so that people can remember in that way. So that explains why 2 centimeter when it is likely to be systemic, and why 5 centimeter when it likely to become suddenly more aggressive. And therefore, the classification is accordingly. And subfractionation less than 2 centimeter because of the screen detected lesion, which is picked up in the West very frequently, and the presence of, which I have not put it here, at least this is a template, so I didn't get the scope to put it here. But one of the issues is picking up in Paget's disease and getting subclinical lesions inside after a Paget's has been excised.
Sir, rounding up the tumor.
Rounding. I mean, what do you mean by rounding, sir? I didn't quite understand the question.
Means we don't get always a 0.5 centimeter or 2 centimeter or 4 centimeter. There can be 2.5 centimeter, there can be 4.2 centimeter.
Oh, so, I see. I see. As I said, most of us, when we clinically assess the lesion preoperatively, again, PGs need to understand. Now, I put it on this mask. Now, suppose you have a tumor here and you try to measure it, you are going to measure the tape like this. So it actually increases the size. So the ideal technique is either putting in a caliper or to take a tangential size. So what happens is that once you do that, you get a rough size. But once you get the whole thing in the histopathological lab, they would cut it and they would section it, the longest and the shortest. And therefore, based on that, the dimension is calculated exactly in the lab to give it whether it is 2.1 or 3.1 or 3.8. And therefore, the prognostication also changes depending on that. There are certain things called NPI, based on which you can actually calculate the exact outcome of the cancer.
So I will add into it, like in the NCCN guidelines, what they have mentioned is, if the tumor, if it is more than 2 centimeter, and if beyond that, if it is a less than 0.5 centimeter, that means 2.5 centimeter can be rounded up into 2 centimeters. Whereas if the tumor is more than 2.6 or 2.5 centimeter, it is rounded up at a higher stage. That is one other in the pathological staging.
Okay.
So second thing is, what is the role of supraclavicular node dissection as it is in the
there is no role, sir. People will go ahead with systemic therapy, and after that, if one can, most of the time, a supraclavicular gland will disappear. After that, apart from in breast, there are 4 portals. Number 1 is an internal mammary chain radiation. Number 2 is chest wall. Number 3 is axilla, and number 4 is supraclavicular. So one can take care of the supraclavicular node initially by systemic therapy, and if still they have doubt, they can put it radiation through the supraclavicular port. That will take care of the supraclavicular node. The role of dissection does not exist.
Have some doubts over here. Right, thank you very much. Second thing is, there are some tumors which will be respond well to the taxane-based chemotherapy. Certain set of tumor, but we are classifying taxane-based tumor chemotherapy as a second line therapy. What is the rationale behind this?
I mean, sir, that's an interesting question. Now, what people usually prefer now triple negative breast cancer, most of the medical oncologists, they go straight into taxane. Again, there are evidences that most of the medical oncologists, if they find that it is a biologically aggressive cancer, they start with the taxane directly. Because, I mean, if you are in a war and you see the enemy has attacked you, there is no point in holding back your navy, that till such time Mumbai is not raided, the navy is not going to come out. That was a concept of step ladder pattern. You first use AC, then you go for that concept of step ladder holds true for biologically non-aggressive indolent lesions. If they come up with a metastasis, they go for a recurrence. It's a non-responder, then you jump up. But if it's a biologically aggressive cancer, there is no reason to hold back your pay. You can straightway go for a taxane right at the beginning.
Last question is, what is the circulating tumor load that can be, whether that should be assessed or it should be directed by chemotherapy, or
circulating tumor load, I suppose you try to mean the circulating cancer cells or the circulating DNAs. Now again, that's a very controversial thing. The controversial thing is, now it's a very complex thing. If postgraduates can understand, what happens is that every single moment we have mutations happening, every single moment. And in every single moment, it is also going into our system. The importance is, when will you call this mutation or this spillage as a significant one is a big question. As of now, we are unable to set that mark, that if you have volumetrically or quantitatively or qualitatively, if you have something above that, suddenly you tell that this is a systemic spillage and this is not. Now, I am sure if you start doing a circulating cancer cell or a circulating DNA analysis of a 2.1 centimeter tumor routinely, with intense amount of measurement, you are going to find them. So that does not mean it's a systemic disease. We have our scavenger within ourselves, which can take care of those metastases. It has not been resolved yet. What is that consensus? But I am hopeful with time to come that standardization is going to come. But before that, for postgraduates, yes, it is a tool of future. There is no consensus to state that this is the cutoff level above which I would stamp it as a metastatic disease.
The thing is, once we say that the tumor is either 1 centimeter or 2 centimeter, it is already a systemic disease, and we have to target that also. So in such cases, and once we say that the unless there is a notifiable malignancy or the secondaries, how that should be addressed?
Sir, I tell you, there had been 3 theories. Number 1 theory came from William Halsted. Now, William Halsted told that the cancer begins in the breast, it grows in size, then it goes into the axilla, and there is a fight between the cancer cells and the lymph nodes in the axilla. After some time, the lymph nodes fail, and then it go into the system. That was Halstedian concept, and therefore the surgery was radical mastectomy, supraradical mastectomy, extended radical mastectomy, blah, blah, blah. Then Bernard Fisher came. Now, Bernard Fisher was the first person in the 1960s who gave the concept of systemic disease. He told that a cancer is like a leukemia. So at the time when we conceive this, it's already a systemic disease. Whatever little or more you do in the breast is unimportant. In 2000, there was a major publication which came up, which is known as the Spectrum publication. The Spectrum publication tells it is a modified thing. The modification is initially for some time it is loco-regional. After that, it becomes systemic. So the second concept is axilla is not a place for protection. It is a place for host immune interaction. So it was the base based on which the sentinel lymph node biopsy was created. That initially for some time the disease remains local and does not go even into the axilla. So the present force is trying to identify whether it has gone into the system, number one. Number two, what is the genetic character of the tumor? Why doing an oncotype DX, and we now have the Indian canasis, if you are able to tell the proliferative risk score is low, the high possibility this small tumor has still not invaded into the system, and chemotherapy will not be essential. So the spectrum theory tells up to certain extent, the average is 2 centimeter, but does not follow that rule. But up to certain extent, it is a local disease and a local regional, then it spills into the system. So if you believe the spectrum theory, it is not really a systemic disease from the first cell, but after some time it goes into a systemic spill.
That means there are the changing theories from the smaller lesion with the systemic theory versus
the spectrum theory.
Spectrum theory. Okay, that is the. Thank you very much. Any other have any questions? Please go ahead.
So there is one question in the chat box. It is like in a case of MRM, the patient has already received adjuvant chemotherapy and later on presents with a lesion on the suture line. So what will be the plan of management? Toilet mastectomy should be done or just go ahead with chemoradiation for such patients?
Madam, that's a good question. What I would do is I would go for excision. If it is an operable lesion, a well-operable unifocal recurrence, I will just go for excision. If it's an unifocal, the margin is free. If it is a locally advanced breast cancer, then as such, I'm going to give a radiation. Suppose it's an early breast cancer, which is where I have done a breast conservation. Now there is a local recurrence. I will excise. If the margin is free, it's a unifocal lesion, I may spare radiation. But if the margin is involved, or if it is a multifocal recurrence, it has to be followed with a radiation. But as a rule, if it's an operable lesion, excision remains the procedure of choice for local recurrences.
So the toilet mastectomy is going to play a role just to reduce the morbidity and prevent further ulceration, or it has a role as an altogether curative one?
Madam, that's an interesting question. Suppose I give a scenario where there is a metastatic breast cancer and there is a local tumor. What will be the role of surgery in metastatic breast cancer? Let us take it very flat and clear. Now, there are two groups. The major study came out from the Tata Memorial, Mumbai by Dr. Badwe and Dr. Vani Parmar, which tells that there is no role of surgery in metastatic breast cancer. The other study came up from the Turkish group, which tells that yes, there is survival advantage by doing a surgery in metastatic breast cancer. So I have gone in details of both of them. Now look at the inclusion and the exclusion criteria in the Tata Memorial group. It tells that they have excluded patients with oligometastasis and they have excluded patients with fungating mass. So if a patient comes with a solitary bone mets with a breast primary, I am going to do a surgery and it improves the survival, which comes with the Turkish group. If the patient presents with a multiple metastasis and there is no fungation, there is no role of surgery. But if the patient develops fungation, there is an issue of quality of life and surgery once again becomes important. So the consensus is non-fungating lesion, oligometastasis, surgery is accepted. But if it's a non-fungating polymetastasis, no surgery.
Sir, I would like to ask a question on this topic only. Role of metastatectomy in metastatic breast cancer.
Question. Now, I have done around 6 laparoscopic liver resections for one or two solitary lesions situated in the liver. I mean, for solitary metastasis, either in lung, I have not done in lung, but in lung or in liver, there is a good role. Leave aside the micrometastasis that has happened. If you can see a metastasis, you can resect it, there is a definite role as of now. But as I said, if it's a polymetastasis, you should not be attempting that. Solitary metastasis in the lung or in the liver can be treated with surgery.
So, thank you, sir.
Question, sir, please.
Okay.
Hello.
Yeah.
What should be the approach? First approach for the recurrence in the axilla, whether the radiotherapy or the primary?
Sir, I would make it very clear to all the trainees that for a microscopic recurrence, any form of therapy is acceptable. For a macroscopic recurrence, surgery is the best solution. If you have a big axillary node, it is always a good practice to go in and do a completion axillary surgery or take out the node. But if it's a microscopic recurrence, which you find in say a PET CT or in an ultrasound, that there are 1 or 2 nodes which are supposedly microscopic, then an adjuvant therapy, you can continue with the adjuvant therapy or systemic therapy or radiation, doesn't matter. But a macroscopic recurrence needs to be taken care of.
Morbidity related to the surgery, because there is a very dense fibrosis because of the primary surgery in around veins and vessels.
Sir, I have the slide with me. I have the presentation with me. We have been doing many of them where if you find an axillary recurrence, you can go in. Initially, there will be adhesion, but after you go in, after some time, you will find the lesions. Only around, say, 1.5 months back, I did in one of my patients where I have done a breast conservation with a sentinel lymph node biopsy. The young lady around 26 years of age did a PET CT just because she wanted to do that. She was finicky about in 26 years of age. She got a small metastasis in the pectoral group of node. So I had to go in from the front, mobilize the pectoralis major. In the level 2, there was a solitary mets. I took it out, excised it with part of the pectoralis minor muscle. The margin is clear, but there was a metastasis. So yes, it is troublesome, but actually if you have that patient, sir, I don't think it will be an issue.
Okay, that was a nice discussion again. So if any more queries are there, you can drop them in the chat box. We'll move ahead with the next session.